Kia ora tātou, everybody. Bruce Arroll's my name. I'm the director of the Goodfellow unit, and you're in for a treat tonight. We've got what's new in lung cancer. There's been a lot of changes, and we've got two speakers. One is Dr. Kate Parker, who's the program manager for the University of Otago, based in Auckland, on the lung cancer screening trial. The screening is going to be coming your way sometime in the future. And our other speaker is going to be Dr. Paul Dawkins, who's a respiratory physician at Middlemore Hospital, and he'll be talking about how we can do early detection better and what's happening in terms of prognosis. So, Kate, over to you.
Thanks so much, Bruce. Kia ora tātou. Ko Kate Parker tapuingoa. I'm really delighted to be here tonight to have the opportunity to talk to you about our research program, Te Aho Kahu, which is basically developing a Māori-led approach to lung cancer screening. So to start, I would really like to emphasise that this work is a real collaboration. So I work with I work with a team that they're shown here. The program is led by Professor Sue Kringle at the University of Otago and co-led by Dr. Karen Bartholomew here at Waitemata District of Te Whatu Ora. So our research group is a Māori collaboration. It's research-led by Professor Kringle, and it's been established through Auckland and Waitemata districts of Te Whatu Ora in collaboration with the University of Otago. In addition to our core study team, the project is assisted by a steering group, a technical and primary care advisory group, and really central to the program design is a group of people who are potentially eligible for lung cancer screening, Te Aho, which is our consumer advisory group, and this is made up of potentially eligible participants and their whānau members. We've also established partnerships with both local and international collaborators to help us do the best job possible. So as I'm sure this isn't news to most of you, but as many of you are aware, lung cancer is a major source of health inequity for Māori. These data here from the northern region show that cancer mortality rates by ethnicity show cancer rates by ethnicity for different cancers. So the left-hand panel is lung cancer, followed by breast, prostate, and other types of cancer. And you can see here the disparity between the green line, which is Māori incidence, versus the blue line, which is European incidence, is really extreme for lung cancer. This disparity is really the largest single contributor to the difference in life expectancy for Māori. It contributes 2 out of the 7-year average in the life expectancy gap, and that's due to a range of factors, including comorbidities, a later diagnosis, and inequities throughout the cancer care pathway. It's also been shown that Māori develop lung cancer around 6 years earlier than non-Māori and at lower smoking exposures. In terms of screening, screening with a low-dose CT scan for lung cancer has been shown to be effective at reducing mortality. International trials have shown a reduction in mortality in high-risk populations of over 20%. However, across the world, there's no current screening program that is equity-focused or that includes sufficient representation of Indigenous people, really despite the burden of disease in these communities, as I just showed you, particularly for Aotearoa. Māori have the highest lung cancer rates of any Indigenous people worldwide, and addressing this presents a real health gain opportunity. However, the worst thing we could do would be to introduce a lung cancer screening program that has inequitable uptake. As you will no doubt be aware, many screening programs across Aotearoa have inequitable uptake, and to do that for lung cancer screening would just make that gap worse. So therefore, any program in Aotearoa must be designed with an initial focus on high-risk Māori. Another complexity is that lung cancer screening is a little bit different to other cancer screenings in that it involves a 2-step process. So because it's a low-dose CT, there are obviously greater risks as well as benefits from the scan, and also greater costs. So the first step in deciding whether somebody needs that CT is a risk assessment. That basically ensures that only people that really need a scan are given one. It's obviously important, but it can also represent an additional barrier to access screening. So basically testing that these sorts of processes work for Māori is really critical in ensuring there are no inequities in either access or participation. In terms of the work that we've done on this screening programme to date, we've focused on several key components. So firstly, an equity-focused reanalysis of the cost effectiveness, consumer engagement to make sure we were designing a programme that worked for Māori, the development of the consumer advisory group, Te Aho, which I've mentioned earlier, and now we're conducting an initial lung screening trial of invitation methods. So just briefly, in terms of cost effectiveness, in 2018, there was an NZ-based analysis conducted that really concluded that CT scanning for lung cancer screening was unlikely to be cost effective for any population group. This was a little bit of a showstopper, obviously, and we were really concerned that equity wasn't really sufficiently weighted in that analysis. So we had questions about some of the assumptions and undertook a reanalysis of that model. And this showed that lung cancer screening was likely to be cost effective, especially for Māori and most particularly for Māori women. It showed that Māori are likely to see greater health gains from CT lung cancer screening, and that the programme would reduce absolute inequities in lung cancer in Aotearoa. So following on from this allowed us to restart the work with more confidence when we conducted a survey of attitudes and beliefs around lung cancer screening. This was designed using focus groups and followed up with a formal survey of around 400 participants and their whānau across Auckland and Northland. One of the key findings that we were really pleased about was that over 90% of participants would be willing to attend a lung cancer screening appointment. So 91% said they would attend, and another 8% said they maybe would attend. So nearly everyone was interested in learning more about lung screening. Interestingly, there was a real equipoise, so a real difference between how people would like to be invited to lung cancer screening. So, and there was a split between people who didn't mind at all, people who wanted to be invited the same way as breast cancer, for example, just from a letter from a screening hub, and around a third of people, particularly people who were worried about screening, who'd had whānau experience of lung cancer, and they really wanted to be invited by somebody they knew, so basically a GP-led process. Interestingly, most respondents were either comfortable or very comfortable with providing a blood sample for storage and future testing for lung cancer research. And there were a number of concerns and barriers raised by a substantial number of participants, including the belief that if lung cancer is found after someone has symptoms, they usually can't be cured, that most lung cancer treatment is worse than the lung cancer itself, and that there was a significant worry about being judged because of being a smoker. And it's really important we bear these concerns in mind as we move forward with our study. So because of the equipoise between how people wanted to be invited, our first study was designed to test the effectiveness of whether a primary care-led approach to lung cancer screening would work better than a centralised approach. So this study is ongoing, and participants are randomised to being either invited by their GP in a primary care-led arm, or by us and nurses that work in our research group in a central invitation arm. The study is underway in primary care practices in the Auckland and Waitemata regions, and we also look at other assumptions that are important for the establishment of a national lung screening programme. For example, what proportion of Māori are potentially eligible for screening, what proportion of these people agree to be risk assessed and then take up the offer of screening, and what's the burden of the process, both participants and also to the GP practices that are involved in inviting people, and what's their experience and acceptability of the whole study process. So in terms of what we've learned so far, we have 26 primary care practices have been enrolled to participate in the study. From these practices, we've invited over 900 people, and 170 people have actually been through the low-dose CT scan out of a total aim of 500 over the next 2 years. We're experiencing a higher than anticipated uptake once people talk through the study with a nurse. So over 90% of those eligible for a scan are taking up the offer of a scan. And we've already detected a number of cancers through screening, meaning they're found earlier and are potentially more treatable. We've also received lots of positive feedback on the importance of the study and how the study is being conducted. And just here are a few examples of quotes from participants who've been through the study and have had their CT. We also have plans and funding to expand the study to assess additional benefits of the lung screen. trying to emulate in some ways overseas offerings, so where lung cancer screening is established overseas. So this includes how could we incorporate spirometry, offering that as alongside screening, which has been shown to improve health outcomes. We're also working in conjunction with Chris Print at the University of Auckland to develop a study to examine how the use of biomarkers may help in interpreting the results of lung cancer screening, particularly looking at AHRR methylation to assess smoking exposure, and a ctDNA panel to assess potential early cancers. This is very experimental, but it's also very exciting work. Finally, we also got funding that's been secured that will widen the study to the whole of the northern region, and that will include Northland and the whole of Metro Auckland. This expansion is funded by HRC and the Ministry of Health, and we aim to begin recruiting participants early next year. The design of the study is slightly different, and the key research question we'll address here is how we can optimise international risk prediction models for local use. So for risk prediction, we're currently using the PLCO M2012 model, snappily titled model there, which has been developed and used in overseas screening programmes and estimates the risk of lung cancer by incorporating age, ethnicity, demographics and smoking history. Assessing how well this performs for MARDI and is really important. For example, are we missing things such as passive smoking, workplace exposure? And it's really critical to the success of a wider rollout of screening in New Zealand. In addition, this new study will include MARDI provider organisations to expand the invitation methodology. We'll also provide vouchers to participants to allow them to invite their whānau or people or friends who they feel might be eligible for lung cancer screening. So basically widening our net of capturing people to be involved in the screening programme. The study will hopefully allow us to gain a deeper understanding of whānau experience in the lung screening, and also aim to roll out an electronic self-assessment to see if that improves access and uptake. So as I said, the programme of work is being developed to inform a national programme, a goal that's indicated into Paitata, but there's a lot to be done. In addition to local research, we're also working with colleagues internationally to explore other things that we need to address to make sure lung screening can be rolled out successfully internationally. These include how we might expedite the acquisition of a mobile CT for screening in remote and rural areas, how we can develop the appropriate workforce and technology for screening, including how we might incorporate the use of AI, how can we facilitate the generation of national guidelines for nodule and results management, making sure we establish clear feedback loops and visibility with primary care, maximising screening to include smoking cessation support, COPD and lung health assessment, and cardiovascular disease risk assessment, and also more work on whether biomarkers can or should play a key role in screening going forward. In terms of primary care involvement in this work, as I've said, our first study of invitation methods is wholly dependent on the involvement of primary care. So we do realise as a research team that in the current environment, it's really hard to sometimes come up for air and look at the bigger picture. But if your practice is approached to take part, please do consider this. It's a really worthwhile study. We've had some really amazing results in terms of finding some early cancers but really positive feedback from participants. So yes, please do consider our request if we do approach you to take part. And if you're part of a practice in the Auckland or Waitemata regions that hasn't been approached by me and would be interested in finding out more, then please do get in touch. Even if you're not part of the study, primary care has a key role to play in the development of national lung screening. And we'd be really interested to know how you think primary care should be involved going forward and what they would need to make this happen. And also, as I mentioned earlier, currently only those at high risk of lung cancer are offered a CT scan. And this really highlights the need for accurate smoking histories to be recorded in order that we approach the right people and don't miss anyone that could benefit. So to conclude, although we've been working on this programme for a number of years, we still have a long way to go on the journey. Ensuring that lung screening is designed to work for MARDI first will ensure that screening reaches those that benefit most. Lung screening has the potential to make a real difference. As I said, we are already detecting cancers early before symptoms develop. But it's essential that any new lung screening programme is designed and implemented in a way that reduces inequities and doesn't increase them. And finally, again, if you're based in Auckland and approach to participate, please do. I'd like to finish and hand over to Paul by acknowledging our wonderful research team, all of our advisors and collaborators, who've been so generous with their time and support of the study, and our supporters at Te Aho and Otago University, and of course the funding from the HRC.
Just to clarify, so this is the pre-screening program research, isn't it, that we're doing? So this isn't available to all practices, only those who get involved in the research.
It's a study at the moment. It's not nationwide or even region-wide at the moment. It's just a study, but there is potential for practices in Auckland and Waitemata to be involved if they'd like to. We've still got lots more scans.
A question about, you're not just doing it in Waitemata, it's all of Auckland, is it?
At the moment, it's Waitemata and Auckland districts. From next year, it'll also be Northland and counties.
Okay, so thank you very much. So great pleasure to introduce Dr. Paul Dawkins. Some of you will know him, respiratory physician from Middlemore Hospital, and he chairs the National Lung Cancer Working Group and Northern Cancer Working Group. So he's got a few new bits of information for us today. So over to you, Paul.
Thank you, tēnā koutou katoa. So I'm giving you a lung cancer update today. I'll be concentrating on early detection, which is a remit of the talk, and a bit about lung cancer pathways, which will be relevant for primary care. I was also asked just to provide a little bit of an update, a brief update on some treatment advances that you're going to see in the not too distant future as regards oncology treatments, immunotherapies and targeted agents. I'm going to give just a brief update on that as well, which was a request that was made. So lung cancer is important. Now the top table here shows the incidence. And as you can see, in males, it's second after prostate, and females second after breast. But when you look at the deaths, you can see that lung tops the table. It is way above breast in terms of mortality, and it's a country mile above any other cause of death in males. And this is globally. Stage is important, and on the left of the screen here, you can see the stages broken down by the 7th edition of the TNM classification for lung cancer, and on the right, the more granular 8th edition, which we use at the moment. And you can see that survival, which is on the y-axis, is closely related to stage. So we really want to capture our patients in these early stages in order to give them the best survival. How does it present by stage? Well, this is American Cancer Society data. It's actually worse in New Zealand. You can see the majority is presenting in stage 3 and 4. So at those points of poor survival that you saw in the previous graph. And when you break down the survival by stage, you can see if you capture lung cancer at stage 1 to 2, which is the first 4 bars, the 5-year survival is much better than when you're down at stage 4. So this is the key to early detection and screening, to capture patients at those stages 1 and 2, where we can actually do something about it and cure them rather than trying to just prolong survival. What about New Zealand? Well, this is incidence data. This is Jason Gurney's slide. He's an epidemiologist in Otago. Now, as you can see, breast cancer incidence is actually higher than lung cancer incidence, even though it only really essentially affects half the population. It is actually more common than lung cancer. But you can see the coloured bars are Maori and the white bars are non-Maori incidence. And you can see what that really jumps out at you in lung cancer is a disparity in incidence between Maori and non-Maori, much greater incidence in Maori. Now, when you translate that to mortality, what do you think happens? Well, lung is way at the top, way above breast cancer, because people with breast cancer can be cured more often than people with lung cancer at present. So you can see that lung cancer mortality is way above any of the other cancers. And indeed, the discrepancy between Maori and non-Maori is quite shocking. In the Maori in the blue at the top, and white for non-Maori. So quite a difference in mortality. So you can see why we're concentrating on lung and why we're concentrating in these pilots that Kate has mentioned initially on the Maori population, because that's where the biggest problem is. So moving on to risk profile of lung cancer, I like this slide. It's a real CT scan, and you may have noticed the packet of cigarettes in the top right-hand corner, and you can actually see the individual cigarettes inside the packet in there. And there's so that's one risk factor, smoking. There's another risk factor on here, emphysema and COPD, which is an independent risk factor for the development of lung cancer, independent from cigarette smoking. So if you smoke 50-pack years and you've got emphysema, you're more likely to get lung cancer than if you smoke 50-pack years and don't have emphysema. And it's about 2 or 3 times the risk if you've got COPD in addition to the smoking you've done. And so you can see the couple of risk factors here, and then you can see the lung cancer in the right lung there. So let's just talk about red flags, because this has nothing to do with pathways. These are the people you want to just refer into ED. So if you've had a massive hemoptysis, and we define a massive hemoptysis as more than 100 mils, so half a bowl full, they just get into hospital. You don't want to refer this patient through lung cancer pathways. Similarly, if they've got stridor, that's a sign of a threatened airway, threatened upper airway, quite a serious sign. Just get them to ED in an ambulance. Signs of SVC obstruction, they're better off in hospital because you want to get them onto dexamethasone and be considered urgently for radiotherapy. So they're best off in hospital. So if they've got a sort of puffy face, a fixed raised JVP, dilated veins that you can see on the chest, just get them in. And obviously spinal cord compression, if you've got neurological signs that suggest lung cancer met, then obviously you've got a threatened cord. So you need to get the patient through into ED. So that's fairly straightforward what the red flags are. Outside of those red flags, you need to think about what risk factors for lung cancer are. Generally, lung cancer is very uncommon below the age of 40 and certainly below the age of 35. So certainly if you've got someone below the age of 35, unless it's an exceptional case, you don't really need to be considering lung cancer. But these are the main risk factors. Number one, obviously smoking, and don't forget secondhand smoking or passive smoking as well. Remember, secondhand smoking doesn't pass through a filter, so actually smoke for smoke, it's worse. Heavy marijuana use is a risk factor for lung cancer. So purely from a respiratory physician point of view, we were quite relieved when recreational cannabis was not passed as, in the referendum. You may have other arguments from libertarian or criminal law points of view, but from a respiratory physician's point of view, we weren't upset by that decision. Occupational exposure, such as asbestos in particular, is a risk. A personal history of lung cancer in the past, you're more likely to get it in the future. Family history of it. A previous smoking-related head and neck cancer is an independent risk factor for getting a lung cancer. And also, as I mentioned already, COPD per se, independent of smoking, is a separate risk factor for lung cancer. So if you've got anybody with these risk factors and they present to you, you should be thinking, have they had a recent X-ray and do I need to get one? And the triggers for that X-ray may be a cough that's lasted more than 3 weeks. Now, I've had a cough that's lasted more than 3 weeks, actually, and there's a lot of it around at the moment with post-COVID and post all the other viruses that you are seeing in your general practice at the moment, I'm sure, because we're certainly seeing it in respiratory. But you might say, well, it's probably not going to be a lung cancer. They've just had a COVID or they've just had a viral infection. But if it's lasted more than 3 weeks and they've got any of those risk factors I've mentioned, just get a chest X-ray. The cough may actually have nothing to do with the lung cancer that's sitting there, but at least you've picked it up. So always worth getting an X-ray. It's an easy investigation to order. Hemoptysis, you need to get a chest X-ray clearly. And then another set of presentations: chest or shoulder pain, shortness of breath, hoarseness, significant weight loss, an unresolving chest infection, and then symptoms that might suggest metastasis from, such as liver, bone, brain, or skin. So these are the indications for a chest X-ray. But I would suggest you have a low threshold in your patients who present to you with risk factors for getting one if they've not had one recently, because you might pick a lung cancer up that's sitting there incidentally, you know, if you get something like this on your chest X-ray, you'll be glad that you've picked it up now rather than later. So as I mentioned, cough, cough, cough. Cough is the thing. It's the most common presentation of lung cancer. And if your patient's coughing away and you're prescribing some cough linctors, maybe think, well, do we need an X-ray here? They've got a few risk factors. This is the Midland campaign, Midland Cancer Network campaign that they call the Cough, Cough, Cough campaign. They had it on the back of buses, on billboards, etc. They took it from the Cough, Cough, Cough campaign in the UK, which was going when I was in the UK, and they actually went a step further. They had advertisements in bus shelters, and they had speakers in the bus shelters that coughed at people when they went into the bus shelter to bring their attention to the billboard that was in the bus shelter. And also their third cough was a splat of blood. They didn't think that was a bit too tough for New Zealand, I think, so they didn't put the splat of blood in the Midland. But the message is there, and you can see they're targeting Maori populations. They've used the Maori colours, etc. in that advertisement. Now, you may be familiar with the quality performance indicators report that came out last year. Now, this looked at routes to diagnosis. So what percentage of presentations of lung cancer come through ED? Because we don't want this to come through ED. We want it to come through the primary care pathways. If it's presented through ED, in general, they're presenting in extremis, and it generally presents late. So basically, diagnosed following ED presentation is a bad thing. So on the y-axis, the higher it is up the graph, the worse the performance indicator. And we've got the number of people diagnosed with lung cancer along the x-axis, and each spot represents a DHB. So you can see there's a lot of variation in this funnel plot across the country. So we've got one dot here, which I can tell you was Canterbury, which was running at sort of mid 20% coming to ED, so 75% through their primary care pathways. And then we've got dots up here. So this dot was Waikato, where sort of mid 55% nearly were presenting through the ED department. So we've got a lot of variation in the country, and we've got to think, why are our patients presenting to ED rather than through the primary care route? And what are places like Canterbury doing that Waikato aren't? So these are the questions that we need to ask. Now, doesn't mean that Waikato are bad doctors or anything. We've got to understand what's different about the services in those different places in New Zealand, and what can we learn from each other. So when should you make an urgent referral? On e-referrals in Auckland area, now you'll have something similar if you're outside of Auckland. This is what we use in Auckland area. It's called high suspicion of cancer, and you click on that box on your e-referral. We like to know an ECOG assessment, which is performance status, because if the patient's ECOG 3 or 4, that is their bed or chair bound most of the day, we know they're probably not going to be on a curative pathway. So that's quite good information for us to have up front. You need to let the patient know. You wouldn't believe how many patients knock up at our lung cancer clinic, and they're no idea why they're there, and when they learn it's a lung cancer clinic, the jaw drops. So it's good to give the patient a heads up. Look, a little problem on your X-ray. It may not turn out to be important, but we've sending you up to the hospital to get it checked out. Now in Auckland area, now this is directed at Auckland GPs, and I have to say, if you're outside of Auckland and Northland, you may have a different system. But in Auckland area, we just want you to do a chest X-ray, and if they've got suspicious cancer, just refer it, because we can get CT scans done a lot more quickly, and PET CT scans. They might not actually need a CT, they could just go straight to PET. And so you've saved an unnecessary investigation, you've saved a wait for a CT scan, you wait a lot longer in primary care than we can get it through our accelerated lung cancer pathway. So that's for us. I would say if you're outside of Auckland, you may have your own systems where the GPs order CT scans, that's fine. But in Auckland area, I'd say to you, please just refer, get the X-ray. If the X-ray is suspicious, refer. And it is an opportunity when you've got the patient in front of you to explore smoking cessation. Outcomes are better even if you've got a lung cancer if you stop smoking. So that is an opportunity while you've got the patient with you, if they're not too sort of stressed out with what you've told them, to explore about smoking cessation measures. So you'll be familiar with the FCT pathway, so the three indicators. So the referral to primary care comes to us in secondary care, and we've basically got 2 weeks to see the FSA. We try and get imaging within that period, CT or PET CT as well. But the 14 days is standard. We try and do it quicker. The second indicator is from the referral to first cancer treatment, which is 62 days, so receipt of treatment. And there's a third indicator, which is from the decision to treat, which is when you've discussed the management options with the patient after the MDM and they've decided what they want to have, to receiving that treatment. It should be about 31 days. So you'll all be familiar probably with these FCT targets. They're no longer compulsorily reported since the Labour government came in, but they are still measured and used in the hospital to assess our performance. Now, in Northern region, as I've mentioned to you now, Waikato are introducing this as well, I know, in various other parts of the country are looking into it, is getting the upfront PET CT. So we've got a dichotomous pathway. So you get we get the referral in, so that from the GP, from basically a chest X-ray, or it might be an incidental finding on a CT. And then from the information we've got, looking at the X-ray and looking at the referral, is this potentially curable? That is, could this patient go to surgery or to curative radiotherapy such as SABR? And if the answer from the information we've got from the referral is yes, we can get an upfront PET CT even before we see them. And that gives us a lot of information at the beginning to decide where we want to biopsy to make a diagnosis, how we want to stage, and that information is very useful up front. If it looks from the beginning that this patient doesn't look curable, the chest X-ray doesn't suggest curable disease, might have a pleural effusion, or you might be able to see bone mets or mediastinal invasion, or the ECOG score's like 4, we say, well, this is clearly not going to be a curative patient, so we'll get an upfront CT instead. Now, if the upfront CT suggests it might actually be curable, they can go up to this pathway and get a PET scan. And similarly, a PET CT might show incurable disease, and they drop down to the non-curable pathway. But it just makes decisions enables decisions to be made earlier on, which is why in Auckland area we don't ask the GPs to get CTs. We might go straight for an upfront PET. And then once we've got all the investigations done, they go to MDM and we decide on the management, which may be curative or palliative. So when we did this in 2015-16 in a pilot, 6-month pilot in Northern region, so Auckland and Northland, we found that we managed to reduce the time of referral to first treatment, so that 62-day target, by 16.7 days. And when you look at percentage achievements, remember this was 2015-16, we're only achieving 62% reaching FSA's 14-day target, and we changed that to 84.8. And referral to first treatment, the 62-day target at that time, is much better now, but we're only achieving 56%, and this pilot improved it to 85.7%. So basically, this system I've shown you, this pathway I've shown you, did cause faster movement of patients, both curative and palliative, through the pathway. So, update on treatments. I promised you this. It's just going to be a brief update on some oncological treatments. So, the treatments that are available at the moment that's going to cure your patient is surgery. We're trying to do this increasingly by thoracoscopic route rather than open route for faster healing time. The radiotherapy, which could be radical or stereotactic, can be curable, sometimes in combination with chemo. And then chemotherapy is given as a cure for limited stage small cell cancer in combination with radiotherapy, and it's also offered as adjuvant treatment following surgery. The palliative treatments available are radiotherapy, chemotherapy, the immunotherapies, targeted treatments such as TKIs, and best supportive care. Now, this is Cameron's slide which I borrowed, and this shows, you'll be aware of these immunotherapies, the new knights in shining armor coming in addition to what we previously have, which is chemo, targeted therapies, surgery, and radiation. We've got a very scary-looking tumor cell there, and so they should be. So immunotherapy, what is it? Well, it's completely different to chemotherapy. Chemotherapy is basically toxic to cancer cells. It's more toxic to cancer cells than your own cells, because cancer cells are more actively dividing. So chemotherapy kills cells, but it's not very good for your own cells either. So immunotherapies work in a different way. Cancers basically can hide from the immune system, and what the immunotherapies do is they bring them out of the hiding place and make the cancer cells visible to the immune system again, so that the immune system can defeat the cancer cells. So this is the blinding with science slide. Don't worry too much about it, but this is a tumor cell here, and the yellow on it is a PD-L1 receptor. So that's a receptor on the cancer cell. You might have heard of PD-L1. It binds to PD-1, which is on the T cells. And when it does so, it sort of inactivates the T cell, so it can't recognize the cancer cells anymore. So what the immunotherapies do is they block that interaction between the PD-1 on the T cell and the PD-L1 on the tumor cell. And they stop that interaction so that the tumor cell can't hide from the immune system anymore. The immunotherapies have a completely different spectrum of side effects than chemo. So chemo, as you know, it's nausea and cytotoxic effects, essentially, immune suppression, etc. But in immunotherapies, you get immune-related side effects, like you see with autoimmune disease, and many of these side effects mimic autoimmune disease. So you might get a sort of rash, or you may get colitis and diarrhea. In the endocrine system, you can have it affecting your thyroid, type 1 diabetes, or hypophysitis. In the liver, you get an equivalent of an autoimmune hepatitis. Pneumonitis is common in respiratory, so in our clinics, we've got to get used to seeing these patients. You may get a neuropathy, you may get nephritis. So the spectrum is quite different. And many of these presentations will come to general practice of people on these immunotherapies. Now, you may have heard that Pharmac have made very positive noises about funding immune therapies for advanced stage lung cancer, and they've put out some requests for proposals, RFPs, in order to decide which drugs to use and for which indications. So there's a list of them here, and the three here are the ones which you're most likely to have heard of or most likely to be approved here. So there's atezolizumab, which is a PD-L1 inhibitor, and nivolumab and pembrolizumab, also known as Keytruda, which is PD-1. So PD-L, it doesn't matter which one it targets. So PD-L1 is on the tumor cell, PD-1 is on the T cell, but it's just blocking the interaction between PD-1 and PD-L1, so it doesn't matter which one it targets. So we will find out which of these are going to be approved and for what indications shortly, but the noises that have been made suggest that it may be in the first half of next year that we'll have one or more of these drugs available for stage 4 lung cancer, which will be great. So where do they fit in? Well, this is a mind map that Led Cameron put together showing the treatment of lung cancer. And just at the bottom, we've got first line and second line treatment for non-small cell lung cancer. So immunotherapy basically fits in second line after chemo, and which one will depend on Pharmac's decision of whether it's pembrolizumab or any of the others that have been proven in trials to improve survival as a second line treatment. It can also be used in first line, and there is a trial of highly PD-L1 positive, so more than 50% PD-L1 positive non-small cell lung cancer, and that trial they've got sort of over 5-year data now, and there's a clear benefit in immunotherapy over standard chemotherapy in this group, and that's just immunotherapy on its own, first line without chemo. So in PD-L1 positive greater than 50%, we hope that pharmac are going to approve immunotherapy first line in this highly PD-L1 positive group of people. There is a suggestion as well, much like with melanoma treatment, that it seems to flatten out around the 5-year mark and plateaus with immunotherapies, which might suggest that there may be actually a survivor effect. And in these people past 5 years, there's a hint that, possibly even a cure, with the same message we were getting with Keytruda and melanoma. So this is a game changing. Now, moving on to a different drug, which you may have heard of, because it's now available. It's been available since the 1st of August. And this is specifically for stage 3 lung cancer that's already had treatment with chemo and radiotherapy. And then you add in durvalumab for at least a year. So the trial was for a year, called Pacific. And you can see the survival curves here. Blue is the durvalumab, and red is placebo. Remember, these have already received chemo and radiotherapy, and it's the next second-line treatment. And there's a clear survival advantage of the people who received durvalumab for a year compared with those who received a placebo. So this is now standard of care for potentially curable stage 3 lung cancer after receiving chemo and radiotherapy, and is now funded in New Zealand, has been since the 1st of August. So it's important that you're familiar with this drug. And it has really changed the landscape of stage 3 lung cancer. So this is Drew Maganakis' slide. He's a radiation oncologist from the States. And in the 40s, they just used radiotherapy, and survival was pretty grim. They added chemo to it in the night. Chemotherapy is followed by radiotherapy in the 90s. And that improved survival. They then did them together, chemo RADS, we call it, combination chemo radiotherapy in the 2000s. That improved things a little bit more. They refined it in the 2010s, refined the regimes, and got better survival. And then the final curve at the top is the addition of durvalumab. So you can see over the course of 70, 80 years or so that the survival has increased in stage 3 lung cancer, and we are actually getting a lot of people survive it if you can fit all the disease within a radiotherapy field. Finally, the targetable mutations. You'll be familiar with some of them. So you will be familiar with EGFR inhibitors. So these are two that are available in New Zealand: gefitinib and erlotinib. Osimertinib has been shown is shown to be useful second line, and also seems to have better results first line as well, but that's not available in New Zealand yet, unfortunately, but hopefully will be soon, because the data is quite clear that it's superior to these first generation TKIs, and certainly in when the tumor gets resistant to erlotinib or gefitinib, osimertinib is useful if they've got the T790 mutation. ALK inhibitor is funded. The one in New Zealand is alectinib. So ALK mutations account for about 7% of lung cancers. We do have an agent for that, and so these give the EGFR and ALK inhibitors give much improved survival. ROS1, there is an agent that makes a big difference called crizotinib, not funded yet in New Zealand, but available in New Zealand, but we hope that will change too. So, and also there's much more agents being researched on for the various other targetable mutations, and this is just some of them here. So in the future, in the not too distant future, we'll be doing next generation sequencing, and we'll have a full genomic profile of the lung cancer, and we'll be able to suggest specific targeted treatments. If you've got a targeted treatment, that should be first line. If you haven't, or then you'll be considering conventional treatment, chemotherapy and immunotherapies. Immunotherapies at the moment have not been found to be helpful in if you've got a targetable mutation, but obviously the landscape is changing quickly. So I've got some take-home messages from my talk. So early detection of lung cancer is important to stage shift. If we stage shift, we can improve lung cancer mortality. Clearly, Kate has talked earlier about screening, which is catching people before they even have symptoms. So there is a distinction between screening and early detection, and that is also very important. So a combination of targeted population screening and then detecting lung cancer early when it becomes symptomatic are key. We have established regional pathways for quick assessment of lung cancer after chest X-ray. Depending on where you are, you may refer with the chest X-ray, or your local secondary care pathway may involve the GP getting a CT before referral, depending where you are. Early PET-CT scans definitely make a difference in terms of the speed of how you can assess these patients on the pathways. The goal is for curative treatment with surgery or radiotherapy. So that's the goal. You want to catch the patients early so that you can cure them. But for the ones that you can't, that are stage 3 and 4 at presentation, happily we do have some new immunotherapies on the horizon available in New Zealand, and one durvalumab available already for stage 3 cancer. We've got 3 targeted treatments available in New Zealand. Hopefully more will become available in the short to medium term future, which will make a difference to patient survival in those who have already presented with advanced disease.
Okay, Paul, thank you very much. We've got a number of questions here. So let me start. Is vaping a risk for lung cancer?
It's too early to say because it's not been around long enough. So you need a big lag time between an exposure and developing lung cancer, so it could be 10, 15, 20, 25 plus years. With asbestos, we're still seeing mesotheliomas now 40 years after exposure. So you need a lag time. We fear it does. There is some evidence in cell cultures in mice and in mice models, so human cell cultures and mice models, where it does, but obviously that's an artificial lab situation. It does concern us, the vaping epidemic. It is being taken up by people who haven't been smokers, young people, and it's clearly marketed towards young people, whatever the vaping companies claim. And we think it's a silent epidemic at the moment, and we're going to see consequences. It may be lung cancer, it may be airways disease. I'm sure that we're going to see consequences, and it worries me that what we're seeing with vaping at the moment is sort of mirroring what was happening with smoking in the 50s. If you look at the tactics of the companies, the advertising, the targeting of it, the denial that it's unsafe thing. We look at the 50s now and we think, how could they not think that inhaling cigarette smoke into the lungs can't be harmful? But yet here we are going, well, vaping's probably all right. Yeah, we're very fearful actually in the respiratory community on what we're opening up for ourselves in the next few years.
One of the things, I was chairman of ASH for 5 years, and one of the things I learned, if the tobacco company don't like what you're doing, you're probably doing the right thing. So
absolutely, and they own a lot of these vaping companies. So if you Google the company name, you'll find that they're a subsidiary of a tobacco company for the majority of the time. So it's insidious, and the tobacco industry has not proven itself to be ethical in any way in the past, sort of 50 years. So why should they suddenly become so now? So yeah, there's a lot of fear from the respiratory community in this. I have to say that's not the opinion of everybody. There are some people who think it's helpful, and it may indeed have a role in sort of hardened smokers who you've tried you've tried nicotine replacement therapy. That it's clearly it's better to vape than smoke. So there may be a proportion of your patients that it may be an appropriate thing to do, and you may encourage. But overall, the big picture is that it's clearly not targeting just that group of people, the hardened smokers. It's got a wider reach, and the school children, the statistics in how many school children are vaping at the moment is quite shocking.
I mean, one of the selling points for the heavy smoker is it's going to be cheaper and possibly better for the lungs. And I've actually taken to begging heavy smokers to quit smoking, and it does seem to work. It does sort of changes the dynamic a little bit. I just say, I beg you from the bottom of my heart, please stop smoking. I don't want to be treating you for lung cancer in 15 years.
Absolutely. Yeah, you can try whatever tactic. Well, the important thing is to bring it up. You know, the brief advice in the GP surgery, 15 seconds of saying, please give it up, does work. You know, just you don't have to be doing a sort of 20-minute consultation, just bring it up. There was a study in pregnant women in the UK where they paid them to stop smoking, and it worked.
Yeah.
But most of them started smoking again after the pregnancy. But yeah, so there's various mechanisms you can use, but the important thing is just bring it up and raise it. And you know, just that brief advice can make a difference.
So we've got Laird Cameron in the audience tonight. He's got a question for you, Kate, and I'd just like you to look down at his second question, Paul, and just see if you want to answer his question. So, Kate, your question is awesome study. Thanks, Kate. Any finding or ideas from your interviews about how lung cancer stigma could be managed to facilitate participation in screening?
Thanks, Bruce. Thanks, Laird. I think, are you talking about? I think you're probably talking about stigmatization of smokers. And I think what we found was that people want to be talked to in a non-judgmental way. So they want to use language that they understand, use compassionate language, offer smoking cessation in a compassionate way, and trying to be sensitive about how and when you offer it. I think Sue Kringle, our PI, has this quote that she likes to use: is hate the smoking and not the smoker. And I think just trying to be compassionate when you do that is really important.
Excuse me, just sneezing, not coughing here. So, question here. Did you see the question from Laird about the mind map, Paul?
I didn't. Can you read it out?
Oh, okay. So just to update that my mind map is outdated now. Everyone should receive the immunotherapy in first line with or without chemotherapy.
Okay. I'll update the slide, Laird.
Okay.
We get to see what pharmac are going to recommend it for. So obviously, once they've made their decision on whether they're going to, it's going to be first or second line, or you know, first line in combination with chemo, whether it's going to be funded for high, you know, as monotherapy and PD-L1 more than 50%. So that this is all needs to be ironed out with pharmac. So yes, once we've got that approval, I'll update the mind map.
Just a question about emphysema. Is it an independent risk factor in those who have COPD but were not smokers? Do they have a higher risk of cancer too? I guess, would it be hard to study that group of people who...
sorry, which group of people?
Who have emphysema who weren't smokers. They've got perhaps asthmatics who've got emphysema.
Emphysema in non-smokers? Not really. I mean, emphysema, if it's not due to smoking or an industrial problem, is really a different sort of emphysema. It's a sort of connective tissue problem. So you see it in Marfan syndrome and some of the connective tissue diseases, and it's really a different thing to smoking related or industrial exposures, diesel, whatever. So I wouldn't say that non-smoking or exposure related emphysema is a risk factor for lung cancer, but it certainly is for, you know, people who work down coal mines, diesel exposure, etc.
Okay. Question here: is there any risk reduction for immunotherapy in earlier stage lung cancer, for example, in people with private insurance and plenty of resources?
No. Well, remember, I've got Laird in the audience who can answer medical oncology questions much better than I can, but it's not, there's no role immunotherapies in early stage lung cancer, stage 1, 2. We've got there's treatments for that stage is surgery if you can do it, or there are curative radiotherapy options. It's maybe stereotactic radiotherapy, or it may be radical radiotherapy beam with a view to cure. Immunotherapists don't have any role in early stage cancer, whether you've got private insurance or not.
A question here from Stephanie: is there any point in routinely doing CT lung scans on all ex-smokers? If so, how often?
Well, that's screening, but that would be extremely expensive, and your pickup rate is going to be quite low, such that it wouldn't be cost effective. So the key is to have a risk factor criteria, which may be based on age, smoking, and some other factors as well that Kate's looking into. It may be occupational exposures. There may be family history involved, personal history of cancers, but various risk factors that could be there, including ethnicity. So your ethnicity alone may change the risk factor profile. So for instance, Kate's group's looking into offering lung cancer screening at a younger age to Maori and I believe Pacific patients, because they have a greater risk in the early age groups. So it's all about capturing as many lung cancers as you can and not causing harm to people with radiation exposure who probably aren't going to have lung cancer, and saving the health economy money, because we can't just go and CT scan everybody who's been a smoker in the country. It'd be ridiculously expensive.
A number of years ago, I looked at the marijuana lung cancer. There was a systematic review, and the only study which showed a relationship, I think, was Richard Beasley's study. And I wrote to Richard, and he says he thinks their study was the best one of those studies, and the other studies are probably not valid. Do you have a view on that? What's your view about cannabis and lung cancer?
I have to confess, I'm not privy to a lot of the data, but I do know that it is an independent risk factor to tobacco. It's very confusing. Where I'm from in the UK, people tend to mix the resin with the tobacco. So it's very difficult to separate. When people have been cannabis smokers, essentially they're smoking cigarettes, they put cannabis resin in. So it's been difficult to dissect. But in New Zealand, where people tend to grow their own, a lot of people just smoke cannabis alone, so and certainly do have an increased risk of lung cancer. So it is a separate risk factor to the tobacco smoking for sure. It burns hotter than tobacco, so it's potentially more carcinogenic to the lungs, and as well as there being a number of chemicals in it other than the cannabis that are carcinogenic from the burning of the leaf.
You can see in screening as well. When we designed our first study, we don't have a risk model at the moment that includes cannabis, but we are looking at how we might be able to incorporate that in the future. And we have had participants, because we also worry that people wouldn't want to talk to us about it. But when we do the risk assessment with them, people say, "But you haven't asked me about my cannabis use," so they're very keen to offer that information. It's something we do need to work on incorporating into the risk profile.
It's an important question to ask as well, because you assume it's all young people, but you know, you speak to grandmothers and things, and you say, "Do you smoke cannabis?" "Oh yeah, every day, yeah." So and not to your typical, you know, you have stereotypes of people who you think smoke cannabis, but you know, at least in New Zealand, there doesn't seem to be any stereotype, and it's an important question to ask, which we often overlook actually.
I had an 86-year-old woman manage to source some cannabis oil from somewhere. But anyway, okay, so if the chest X-ray is normal and high risk, you refer in 3 to 4 weeks? I guess that would depend on symptoms, wouldn't it? Like the cough still going. And
if the chest X-ray is normal,
yeah.
Well, the normal chest X-ray is extremely encouraging, because if they're presented with a cough and they've got normal X-ray, then it's very unlikely that there's a lung cancer there, because if it's a lung cancer causing a cough, you're probably going to see it on a chest X-ray. There may be a little nodule there that you can't see on the chest X-ray, but it won't be causing the cough. So immediately when we see that, we won't make it a P1, see in 2 weeks, because it's very unlikely they're going to have a lung cancer with a normal chest X-ray. If there's worrying symptoms like coughing up blood or other red flags, we may still see it as a P1, but not in the accelerated lung cancer pathway. So, you know, it may be 2, 3, 4 weeks if it's a P1. If it's just sort of, you know, you get the referral generally fatigued, lost a bit of weight in a normal chest X-ray, to be honest, we're probably not going to give a P1 for that, because the pickup of a lung cancer in somebody who's got a normal chest X-ray with that presentation is going to be quite low. So we'll prioritize that a little lower, which might irritate you, but you know, we have to get the, you know, it's all about probabilities. We want the patients who probably have got lung cancer seen quickly, because if you start seeing all the ones that might have lung cancer quickly as well as everybody else, the people who generally got lung cancer are going to wait longer. So it may irritate you sometimes when you've made referral urgent and we bring it back as P2. It's nothing personal. It's just we've got to work on probabilities.
Yeah. Could you just discuss the fast track CT again? Just what the fast track CT is?
Well, I should say in Auckland region we have a slightly different pathway to others. So which is what, but basically you refer the patient having had the chest X-ray with the letter through the high suspicion of cancer electronic pathway, and we'll look after the rest. So we'll look at the chest X-ray and the letter. We'll order a CT or a PET, depending on whether we think this is potentially curable. So basically, we've potentially saved money and radiation from a CT if they're going to end up having a PET anyway. Do you see what I mean? The patient has a CT and says, "Oh, you need a PET now." Yeah. Which is, you know, so you've wasted. You know, $1,000 for a CT, whatever it is, and you've wasted, you've given the patient radiation, you've wasted time. So we found it a lot more efficient to actually decide, is this patient curable? If they are, just get the PET, and we've got regional permission to do that. So a number of them will be unnecessary PETs in inverted commas, because they'll turn out to have advanced disease. But you know, that's the price you pay for getting patients through the pathway quickly. I'm not suggesting we do PET on everybody, just the ones that we look potentially curable from the chest X-ray and the information we've got available to us.
So those PET scans done in the public system or the private system?
The PET scans in Auckland, we've got the 3 PET scanners now, and they're all in the private sector, but they have a contract with Te Aho to provide that service to the public system. So the patient doesn't pay for it. Right. But there's no PET scans in Auckland in the public sector. We haven't found that to be a problem. In fact, because it's a private sector, they run very efficiently and they're very cognizant of quality and getting the scans on time and everything. The private sector are very good at that, better than the public sector. So what we actually find is that we are getting quite a good service out of it. It's not all bad, the private sector. Getting scans quickly and efficiently is what they do in the private sector. So whether you could argue, well, they're making money out of the public system, we should buy a PET scanner in the public system, so the third party isn't making money. That's a reasonable argument, but it's quite an investment to PET scan. It's very expensive.
Okay, you made a little comment there about doing the gene sequencing in New Zealand, because I mentioned to you about I have a relative with lung cancer, and his gene testing was all sent off to the United States to see what drugs he would do. So do you want to is that going to change here? How's that going to help things? I mean, that's more a question for you folks than GPs, but
yeah, I mean, it's all about funding again. You know, we'd love to do whole genome sequencing and next generation sequencing on all our patients, and we will be, you know, in 5 years time we will be doing that for sure, when, you know, we have a number of targeted treatments. I can't imagine a situation where we won't be doing genome sequencing in 5 years, but it's just getting there that's the problem. You know,
so your choice of drugs is often dependent on what the genome of the tumor is that right?
It is, and the other argument is, well, what's the point having sequencing if we haven't got any drugs available? Yeah, that's an argument, but I would argue that you should know and at least give the patient a choice of buying them, or they might have an Australian US passport or something, and they can access the treatment in their own country. So I think people should have that information, and also it's good lobbying power if you can say, look, we've got all these patients here that we could have put on a treatment that could have lengthened their life, but we couldn't because it's not funded. It's quite powerful argument to make for when to Pharmac and the government, you know, to say, look, we want these drugs funded and New Zealanders are missing out. So yeah, so the reason why we're not doing whole genome sequencing is entirely a combination of fact, first of all, it's expensive and not funded, and secondly, at present, we haven't got many drugs. We've only got 3 targeted treatments actually available in New Zealand funded. So you know, there's little point spending a lot of money sequencing if we, at the end of the day, we've got nothing to offer them.
Right. What's an ECOG assessment? You did mention it. I don't think you described it.
Oh, sorry. ECOG. It's a performance status assessment, and on the referral forms here, it's you click on it and it'll tell you what each of the scores means. So 0 is normal for to compare with their peers. So 0 for a 30-year-old is going to obviously be different for a 0 for a 90-year-old. It's what you expect them to be for their age. So 0 is normal, and then 1 is a little held back compared with the peers. 2 is limited in activities of daily living, but up and about for more than 50% of the day. 3 is the same, but less than 50% of the day, and 4 is bed or chair bound. 5 is dead. So yeah, so that's yeah, so that's a lot of people are familiar. Like if you're not, it's on your referral form. It's spelled out as a drop-down box exactly what each score means. So basically, ECOG 0 to 2, you can think about surgical treatment. 3 and 4 probably not. That's a rough ballpark. You might stretch that sometimes to stage. Okay. You know, ECOG 3 with a small cell, you might push the boundaries a bit.
Okay. Is vaping okay in pregnancy?
I think the general rule is try and put as little potentially toxic substances into your body as possible when you're pregnant. I don't think there's any evidence that it's harmful, but you know, it's how can you do a study of vaping in pregnant women? I mean, it's impossible, isn't it? So my advice would be don't take it up in your pregnancy. If you're on 40 a day, then maybe vaping might be a better thing to do.
Do you have a view on the flavorings versus just the pure nicotine? I've been encouraging patients to avoid the flavoring, but that's just based on the thought that the flavoring may be doing some of that popcorn lung thing.
No, well, there was one additive which was vitamin E, I think, wasn't it? Vitamin E based in America, and that was what caused some of the problem in the lung, and it was adding cannabis sort of extract into the vaping. The additives, you know, there's no evidence they're any more harmful than non-additives, but the fact is that why are they adding things to it? Well, they're doing it to market it towards younger people. But that's why you might see legislation saying you can't put additives in, not because the additives are dangerous, but because you don't want to target 13-year-olds with it by making it strawberry flavored or hokey pokey flavored or something. You know, it's clearly not. You're not targeting the 40 cigarette per day smoker with flavorings like that, are you? You're targeting a different group of people. So that's the main concern about additives.
So I've got one more question. If you've got any more questions, you need to get your fingers on the keyboard now. Yep. Okay. Just a general question in terms of hospital policy in regards to people smoking in front of the hospital and whether a separate space would be more preferable. Examples of this are Auckland Hospital and Middlemore. Any view on that, either of you?
Do you have a view, Kate? Smoking in hospitals?
Oh, I think, yes, as far away as possible. I think that, yeah, I mean, I think certainly White and Taurus, the whole site is no smoking. You can't smoke in front of the hospital. And I think that's a good thing.
Got a comment from Christine McIntosh about safety in pregnancy. She's the SUDI expert. No evidence of safety in pregnancy, but absence of evidence, I guess. But remember, nicotine effects on fetus, reduced growth, and therefore a connection with sudden death, sudden unexplained death syndrome. So thank you, Christine. And we've got one more question. A South Australian scientist who presented Respiratory Foundation conference in 2000 recommended that flavors have multiple carcinogens and are not approved for inhalation. Sorry, I can't remember her name. Any further comment? Happy with that?
Yeah, you know, there's a lot of rubbish in them that we don't know.
Okay.
There's 260 chemicals in a typical vaping cartridge, and it's including the additives and what have you. The fact is, you know, in a laboratory, yes, they do appear to have a certain amount of toxicity, but we don't know yet what effects they're having on humans.
Well, we're just about out of time, and we've perfectly finished our questions. So any final words from Kate, and then final words from Paul, and we'll bid you all good night. Final words, Kate?
Thanks very much for the opportunity, Bruce. It's been great to be able to share what we're up to. And as I said before, if anyone's keen to learn more in primary care, please get in touch.
Okay.
Thank you.
Paul.
I'll just say, I'll just remind you of the staging graphs I showed with majority in stage 3 and 4, and also the data on presentation to ED. So from the general practice point of view, you know, we need to be picking those patients up at stage 1 or 2, so that you may have opportunities when they come in with their coughs and for their cough inctuses and what have you. That there are some opportunities there to get the X-rays earlier in the day, and also we need to get you know, more referrals through the GP route than through the ED route, because the ED route generally is later.
So more chest X-rays from primary care?
Yeah, essentially we've got to work on access to chest X-rays. I know it's a problem in Auckland.
Yeah.
Because the GPs have a certain budget, then they want to use them for ultrasounds, and they use the chest X-ray. They haven't got a budget to get their ultrasounds done. I mean, it's ridiculous, really. Or they can pop to the hospital in Middlemore and have one for free, the walk-in service. It's not exactly accessible for people who live in Waiuku or something. You know, it's you know, and they can go to a private provider, but they have to pay. And so who's going to pay $80, $100, whatever it is for a chest X-ray? So it seems like a simple thing, but there are actual barriers there in the way we've set up our health service, in that it is difficult for GPs to access chest X-rays. So I've had some conversations with Campbell Brevner in Auckland region about how we can make life easier for GPs to get a chest X-ray without burning into other the budgets for other things, and also perhaps involving, you know, pharmacists, because when people have got a cough, they go to the pharmacist.
Oh, yeah.
Maybe we can get pharmacists involved in it as well. Yeah.
We routinely exceed our budget. Nobody seems to come after us about it. So I maybe encourage you to, but the Middlemore service is great that you can just walk in. That's fabulous. Okay, so the fan club has joined in to say thanks, team, awesome presentation, and thank you, Kate and Paul, for a wonderful evening. So, okay.